Hello everyone, welcome to this session on adaptive deep brain stimulation and Parkinson's disease. My name is Pieter Kubbe, I'm a neurosurgeon at Maastricht University Medical Center. I'm going to tell you first about Parkinson's disease and deep brain stimulation, and then we're going to focus on the adaptive deep brain stimulation. First of all, what is Parkinson's disease? Parkinson's disease is a neurodegenerative disorder which is characterized by a few hallmark symptoms. The first and most important one is bradykinesia, which means slowness and stiffness in movement. Then there is rigidity. It's a specific sort of stiffness also indicated by the cogwheel sign, which means that movement goes cogwheel-like. It's not a fluid movement. Then there is the typical tremor, which is a tremor in rest, which mostly starts asymmetrical. And it's characterized by a frequency between 4 and 6 hertz. And then last, there is a decrease in mimicry, special facial mimicry, which also is one of the hallmark symptoms. Then what happens in the brain? Here you see a coronal section, a coronal slice of the brain, in which you see the thalamus, which is the main relay hub in the brain. Below the thalamus, there is a subthalamic nucleus. And below the subthalamic nucleus, there is a substantia nigra, which literally means black matter. And this contains the dopamine, dopamine-producing cells. And a cell loss in the substantia nigra is the cause, the physical cause in the brain of Parkinson's disease. Now, how can you treat it? First of all patients who start treatment for PD, they start with drugs, mainly a synthetic dopamine, which is administered in oral forms, tablets. You also have the option to deliver apomorphine, another drug, directly into the duodenum, so into the intestine. But most people do fairly well, especially in the beginning of the disease, on drugs. If drug treatment isn't sufficient anymore, then intracerebral therapy is possible. Decades ago, the primary choice was lesioning, so damaging a piece in the brain. Then neuromodulation became available, which actually mimics the damage, but which is totally reversible because high frequency stimulation in the brain actually mimics the effect that you could also cause with the damage. And now, very recently, new, safer lesioning techniques have found their way back. Besides radiosurgery, there's also the opportunity for focused ultrasound, which is still being explored, especially in unilateral cases, but it's one of the promising future options. Now, focusing on either lesioning, but in our case, stimulation, how do we reach the part of the brain we're interested in an accurate manner? Because it's about between 7 to 8 centimeters below the brain surface, below the cortex. And the area which we're interested in Parkinson's disease, mostly interested in, is about 3 by 3 millimeters. So to reach that accurately, you first of all need to define in a coordinate system where exactly do I want to be, and then you need the physical tools to reach this well. And the technique for this, it's called stereotaxy, which comes from the words stereos, which means cubic or solid, and from the word taxis, which means order. And if you combine those, you get stereotaxy. So we actually order the structures in the brain, the coordinates in this case, in a cubic system, which gives you 3 coordinates for the target, x, y, and z. And you want to have a linear trajectory. Actually, you only can have a linear trajectory to your target. The point is that all heads have different sizes, so you can specify a target with coordinates, but you can't really specify an entry coordinate because you never know, based on the physical shape of the head, where exactly that is going to be. So this technique is already about 40 years old. Not the tools we use, but the technique itself. And a quite clever construction is you define a target and you define a direction. So instead of having a specific entry point, where exactly would you do that? You define a direction, which means you have to specify two angles. If you have a 3D space and you have one point fixed, which is a target, you have still 2 degrees of freedom left, and in this case that's the X angle, and it's the Y angle, and they're called the arc and the ring respectively. So how does it look? What we do under mostly local anesthesia, we mount a frame on the head of the patient with 4 pins going onto the skull. And with the frame, we make a scan, which we use to calculate the final coordinates. And then we mount the arc and the ring actually on top of the frame, which you see displayed in the picture. And this gives us the opportunity to set the target coordinates, coordinate X, Y, and Z, and the direction by the arc and the ring. And this is how we actually reach the target fairly precise. The inaccuracy of this system is about 1.5 millimeters in the brain stimulation surgery. The other thing which we use to get to the best possible target is microelectrode recording. And this is something which is still under debate in the stereotactic community for DBS. The idea behind the microelectrode recordings, or MER, is you don't insert one electrode, but you insert up to 5, mostly in PD it's 3, microelectrodes to record, but also to stimulate, which means that we like the patients to be awake. You could do some measurements actually under anesthesia, but the best recordings and definitely the most useful stimulation effects we get when patients are awake. So we bring in the electrodes, we start about 10 millimeters before the target, and then we go deeper in steps by 1 millimeter or 0.5 millimeter. And we look at the signals, we listen to the signals, and when we get to the target coordinate, we see changes in the signal, which we use to define the theoretically best trajectory. And then we confirm if this is really the best trajectory by stimulating to see what is the effect, and also very important, what are side effects. And based on the combination of these two, we decide what is the final place for the electrode, the definitive lead. So the good thing about MER is you get intraoperative neurophysiology. You get to explore the structures in the brain in real time. It helps to get optimal accuracy. And it's important to realize that the planning we do in MRI, MRI is a very important and useful imaging modality, but it's not an absolute truth. Stuff we look at T2 weighted imaging, for example, iron artifacts, you need to have some caution in interpreting the MRI signals, and MER can actually help to get more data to make a better decision. On the other hand, I already told you patients need to be awake, which is one of the things. And the other, with future developments in DBS, improved MRI, directional steering, robotics for implantation, the debate whether MER really has its added value and it's worth the effort for the patient being awake, also the time effort in the OR, will again be under debate. So if we have all this, then where exactly do we want to be? Well, for Parkinson's disease, the most chosen target is the STN, the subthalamic nucleus, which was already displayed in the coronal brain section. And it's actually the overall champion for PD DBS, because it helps to alleviate response fluctuations, bradykinesia. It also helps to reduce tremor. So for most typical Parkinson patients, this is the neurosurgical anatomical target of choice. However, if patients have mostly dyskinesia, which is a disturbed movement pattern, bradykinesia is a slow movement pattern, this is a disturbed movement pattern, the GPI, internal globus pallidus, is sometimes used. There's also some larger studies being done, differences between STN and GPI. Mostly favor STN, but not all of them. So it's also partially surgeon preference maybe. And the other target, the VIM or PSA, VIM stands for the ventral intermediate nucleus of the thalamus, and PSA stands for the posterior subthalamic area, which is slightly deeper and more to the posterior side. And this structure is actually preferred when there is a tremor dominant Parkinson patient, or for example, essential tremor patients. They also get DBS if they get DBS in this area, mostly nowadays trying to target the dentral-rubral-thalamic tract. So these are the anatomical targets. Now we know where we want to go, we know how to get there. I already told something about directional steering, which is a very important development in the past few years. This is actually how an implanted lead looks like, actually the tip of the implanted lead looks like, which we use for Parkinson's disease. We have contacts which are about 1.5 millimeter long, and the interspacing between contacts is 0.5 millimeter. The typical DBS lead for PD has 4 segments, 4 contacts at the end. And with directional steering, in the current lead developments, the middle 2 contacts are segmented, which means if the stimulation is activated, the current is not going in all directions, but specifically in the direction in which you want. So with the traditional, in this case silver-colored contacts, you get omnidirectional stimulation, current going in all directions. With directional steering with segmented leads, you can selectively activate/deactivate a specific segment, which allows for getting the current in the direction in which you want it, and thereby avoiding current in the areas in which you don't want it. And the reason why we want this is to increase our therapeutic window. It's not only about directional steering, you have more options. So again, the active segment is the first thing you choose. MER can help, the MRI helps. Still, it remains to some extent trial and error. So in each patient, you have to find the optimal settings individually. And you not only try to choose the best active contact or segment, but you're also concerned about how much current, milliamps, millivolt, can we give. Obviously, if you stimulate too low, then you don't get effect. If you stimulate too high, you get side effects, and you try to have the maximal window between getting effect and getting side effects, for which directional steering is very important, very helpful. But it's not only about that. The other things are the pulse width. So you see the stimulation waveform, which is kind of on, off, on, off, on, off. A typical pulse width for PD is 60 microseconds, and modern pulse generators also allow to go lower, which seems to improve symptoms, actually reduce side effects. And the fourth one is the frequency. So these 4, the active segment or contact, amplitude, pulse width, and frequency, are the kind of parameters which we use to configure stimulation, and all these can be changed from outside. So there is a patient controller, which is, depending on patient and physician preference, some options. On the physician controller, there are even more options, and all these things can be changed from outside, which is very good, because if it's not optimal, then you can always change it after surgery, even years later. And again, as said, the goal is to maximize the therapeutic window, which translates in this case into the volume of activated tissue. So the combination of these parameters will give you the volume of activated tissue, and there where the tissue is being activated, modulated, how you wish, because it's not actually, it's called activation, but as I said, high frequency stimulation actually gives more sort of inhibition, lesion effect. But the volume of modulated tissue is actually important because this determines the overall effect. Now, how does the total system look like? We focused on the lead. The lead is connected with extension cables to the pulse generator, which can be either implanted in the chest, infraclavicular, or in the abdomen, paraumbilical. And the extension cables go under the skin between the lead and the pulse generator. So the kind of shopping list, if we have to do an implant, you need for a bilateral implant 2 leads. You need 2 burr hole covers, which is used to fix the lead in the position where it needs to be, because obviously if it would move after surgery, then it can be, first of all, dangerous, but second, the effect would change all the time. You have then on the shopping list the extension cables, the 1 pulse generator for 2 sides, and the patient programmer. Now, the brain stimulation is a safe procedure, but obviously it's brain surgery, so it has risks. And the first category are the surgical risks. Bleeding in the brain is what patients are mostly concerned about. The chances are very small, less than 1% per electrode, about 0.1% per electrode actually, so 1 bleeding 1,000 trajectories electrodes. The MER electrodes do count in this one. The thing which the physician is mostly concerned about is infection, because a foreign material in the body, that could be a spinal screw and rod, but also electrodes, they're more prone to an infection. So this is our major concern actually. Obviously, the concern is about a neurological deficit, or in the worst case, the death of a patient, which is very, very rare. And then it would be primarily related to a bleeding. So fortunately, very rare. And when we tunnel the extension cables, we have to pass the clavicula, which is, so the lung is actually directly beneath it. There is a risk of a lung puncture if you would go under the clavicula instead of over it. Also, this one is quite rare. Second, it's still hardware which we implant, which means it can go broken, it can have defects. Some traction on the cables or the scarring about the cables can develop. And the pulse generator can be rechargeable, can be non-rechargeable. There is a reason to choose one or the other. Rechargeable is not always better, but if it's not rechargeable, it needs to be replaced, which is actually a small surgery, outpatient clinic, local anesthesia, but still has an infection risk. And the last category is the stimulation-related side effects. The good news, these are reversible. But again, we're trying to find the balance between as much effect as we want and as less side effects as we want, so the therapeutic window. The exact kind of side effects will depend on the anatomical location of where you stimulate, the volume of activated tissue, modulated tissue. And for Parkinson's disease, mainly paresthesias, so tingling, diplopia, double vision, dysarthria, so disturbed slurry speech, like you drink too much of alcohol. Those are the most important ones, which we also test during surgery with the MER. And specific, if you go too anteriorly in the STN, you can have mood disorders, especially hypomania is from the past in a negative sense well known, if it occurred. So far the explanation about PD and DBS. Now, what you need to know is that PD has a fluctuating pattern. I already mentioned the term response fluctuations, which is the major indication for STN surgery. STN DBS. And this response fluctuations means that patients vary between an off situation in which they have the full amount of symptoms, medication actually is kind of wore out, and when they get a new medication intake, they get back to the on situation, which means they can function under circumstances fairly well. So they have actually the best situation, and then when medication wears off again, they go back to off, and after medication intake to on. So this fluctuates during the day, and this can fluctuate every 4 hours, for example. But the DBS doesn't take this into account. The DBS, the current is always on, and yes, you can use all kind of parameters to find optimal stimulation pattern, but the pattern is always the same, unless you change it manually. But you're not going to change it manually every 4 hours or every moment. So what you would like to have in an ideal situation is an adaptive system which actually takes these response fluctuations, so patient performance, into account. So if you want to do that, then Adaptive DBS is also called closed loop DBS. So you pretend you're going to close a loop. Then the question arises, what loops? What kind of loops could you close? Well, the first one, it's one of the most well-explored options in adaptive deep brain stimulation. It's based on the local field potentials, LFP. So the neurons, the cells in the brain, they have a firing pattern, but neurons are very small, and groups of neurons actually cause a field of firing. And this field is called, what you measure there, the potentials you measure of these fields, these local fields are called local field potentials. And you can use them as an input signal actually to close the loop in DBS, which we're going to focus on in a couple of seconds. But first, another mechanism is ECOG. ECOG stands for electrocorticography. So it's measuring the brain rhythms at the surface of the brain. And as you see in the drawings, the LFP DBS, you can, like conventional DBS, have one pulse generator controlling both sides. I mean, it's specific hardware which you need. Not all systems allow for this. But the systems which allow for this approach, they have technology built in which makes it possible to sense the local field potentials in between stimulation in a way in which the measurements are not tempered by stimulation, because the stimulation strength is much bigger than the LFPs which you want to measure. If you do ECOG, then you need one system per side. So you need actually one port of the battery for the strip, the ECOG strip, and you need the other side of the battery for the stimulation. Then the third category, it's done by using wearable sensors. For example, smartwatches, accelerometers around the wrist, smartphones. This is a completely different approach, and you could in this case also do with one PG. So first of all, focusing on the local field potentials, then we're mainly talking about the beta band in the SDN. The beta band is the area between 30 and 30 hertz. You can measure this, and the issue in Parkinson's disease is that you get hyposynchronization, excessive synchronization within the beta band, and this is something which you can measure. The problem is that this excessive synchronization is actually a break in the brain on the execution of movement. So if you detect this hyposynchronization in the SDN, in the beta band, it's something which you would like to counter because it actually will help to improve symptoms, which is possible. And it has been explored in two ways. First, it's just on-off, and this on-off is actually not related to the on-off in response fluctuations. The on-off in this case is when the hypersynchronization in the beta band is detected, the stimulation turns on, and when this hypersynchronization is actually normalized again, then the DBS system turns off, so it's just on and off. The other approach is more gradual, in which you modulate the amplitude and say, okay, if we detect an increase in hypersynchronization, we're going to increase DBS stimulation, and if we detect a decrease in hypersynchronization, we're going to decrease stimulation. In the studies which have been done, they found up to 30% improvement of symptoms, and also very important when you're talking about non-rechargeable batteries, over 50% improvement of battery life. Both are very good. So the good thing about this LFP approach, it has been proven to have a good effect on bradykinesia. It has a good effect on speech, less side effects, less dysarthria, and it improves battery life. On the other hand, the tremor, which is actually less of influence on quality of life in PD patients than bradykinesia, but the tremor correlates with a gamma band, which is tougher to measure with this system. Experiments which have been done are still kind in a very controlled setting, lab setting. Voluntary movement actually influences the beta band, and in resting tremor, the beta band can be attenuated, decreased, which makes it more difficult to detect it well. So this is about LFP ADBS. Another thing which has been explored by 1-2 groups actually, it's using ECOG, electrocorticography. And this ECOG input for adaptive DBS is based on the principle of phase amplitude coupling, which means that the beta phase in the STM corresponds with the amplitude in the gamma band and the primary motor cortex. And if you know about this correlation, you could turn it the other way around and say, then I'm going to measure the gamma band in the M1 in the primary motor cortex using a subdural strip. And this feedback, I feedback into the pulse generator, which is equipped with the how to handle these data. And this is actually being fed back to the lead in the end to give appropriate stimulation. There's not so much clinical experience yet with this approach, but again, it's still being explored by a few groups. And then the third approach is using the wearable sensors. As I said, you can use smartwatches to benefit from the built-in accelerometer, and if you want, also gyroscope. I mean, the gyroscope is good for rotational information, which can be helpful, especially in tremor. It will consume more battery, so there's a balance between added value and decreased battery life of the watch. The second component is a smartphone, because with the other two approaches, LFP and ECOG, you actually try to get some biophysical markers, some brain biomarkers about PD. In this case, you're going to measure the end effect, but the accelerometer and or gyroscope will only give you information about movement. You don't know anything then about speech, which is a very important issue in deep brain stimulation, dysarthria. You don't know about mood, you don't know about cognitive function, so you need to measure in a different way. One of the approaches which could help is EMA, ecological momentary assessments, also sometimes abbreviated as ESM. And by using this, you can actually complement your movement data, your kinematic data, with other relevant patient data. And to finalize the model, you're also going to need to know the DBS parameters, because you can imagine that if I have optimal movement and also acceptable side effects, I need to have input in the model which kind of DBS parameters do cause this to actually calculate back the other direction. Can you then, based on the input of the accelerometer and from time to time the EMA, optimize DBS stimulation settings? And this is one of the things we are currently exploring in our group. Then, when you have all these very nice inputs, you still need to process the input to do something useful. So I intentionally skipped the AI component, machine learning, deep learning, whatever you want to call it, in the previous slides, but it's going to be very, very important in our work that using the signals, combining the signals in an appropriate way, will be the foundation to get good working, satisfying deep brain stimulation in a fashion. One of the open things is white box versus black box algorithms. I think most of you will have heard of the XAI, explainable AI trend, which partially relates to GDPR and MDR in Europe, so regulatory affairs. It will be interesting to see how this direction goes. When it comes to clinical decision making, I think almost all physicians will have a quite strong preference for white box AI. And for this kind of work in which there is no human in-between action, on one side, there's quite a strong voice for optimal performance, even if it means black box. On the other hand, because you will be directly influencing the function of the brain, explainability will be very important. So this is one of the things actually I don't have an answer to. Then how does the future of DBS look like? And I mean, this topic can be very broad, but a little bit in the context of what we discussed and which I explained. First, directional steering will be of increased importance. A large study led by Alfons Schnitzler from Düsseldorf has shown that you get about 90%, 90% increase in therapeutic window if you use directional steering, which makes sense, which is totally believable, and which is actually a fairly simple method already to improve patients' quality of life. Directional steering cannot actually solve the response fluctuation issue. So for that, we will need adaptive closed-loop DBS also in whatever form. Third, novel waveforms. I mean, in the waveform of the stimulation, there's also something to gain. Studies about coordinated reset, for example, have shown that, and I think for the next few years we will see other innovations in the waveform section. Ultra high field MRI, 7 Tesla, maybe even higher. I mean, protocols are currently being improved and get better every year, so it can help to optimize the planning for the DBS. And if we combine it with robotics, a robotic arm, to improve the accuracy of stereotactic surgery, I think this is also going to be an important contributor to improved deep brain stimulation surgery outcomes. Having said that, I'm going to conclude this session. I hope you enjoyed. I hope you got some more information about Parkinson's disease, about deep brain stimulation, and about adaptive deep brain stimulation. If you want to rewatch the video, you can go to this website, click the YouTube link, and if you have any questions, you can reach me with the same media. Thank you for watching.